So Nick, how have you been?
Yeah, no, it's been good. Obviously, it's half term.
Yeah.
And just been hanging out with kids, and sort of TV becomes a little bit more of a focus in the evenings. Anything you've watched recently?
Yeah, no, you're right. TV has been a focus for us this week, daytime and evenings. Yeah, we've been watching Gold on BBC iPlayer. It's a mini series all about the Brinks-Mat robbery.
Yes.
When they stole all the gold back in the 1980s, and how they spent the whole time trying to find a missing £26 million, which was a lot of money. It is a lot of money still. And I kept wondering to myself, there must be analogies in health with trying to find millions and millions of pounds that has gone somewhere and nobody can figure out where it went to.
Well, back of the sofa.
Back of the sofa, yeah. How about you? Seen anything good?
Yeah, no. So I've been watching Clarkson's Farm, and obviously that polarizes people, but it's an absolute hoot. And the West Oxfordshire Council has really come out bad from this. And I think, and so my kids have then been, on the surfing on the internet to see what the council is saying about the latest show and everything. And what's interesting for me is that suddenly the council have become the sort of the evil, the dark side. And I feel that they're pretty much the same as accountants, So just to segue there into to Tim. I don't believe that for a second. So how are you doing, Tim?
Very good. I'm struggling a little bit with the title of this, the dark side of value, because me and my colleagues thought the dark side was you guys, but I'm quite happy with the arrangement to talk about it, to give the case for the defence. With regards to television programmes, I think I'm going to get a refund from the BBC licence fee with this one, because the number of people I told about Traitors, I don't know whether you watch Traitors, but I urge you to go back, have a look on Catch Up. Lots and lots of people have watched it. I haven't heard anyone say it was right. I don't know whether it relates to me working in finance that made me think that Traitors was a good programme to watch, but I suggest everybody go and look at that. It is good.
Excellent. So if we've achieved anything today, it is some recommendations.
Yeah, I know what to do next week in the evenings. Yeah. Well, look, Tim, welcome to our value-based healthcast. What I'm going to do, I'll give the viewers or the people who are joining us a very quick intro to you. So Tim Kelland, you're an accountant by background, although you've got a very broad range of interests now, and you're the assistant director of the finance delivery unit in NHS Wales. And I was told that you've been 39 years in the NHS. Is that right?
Yeah, I know I don't look it, but I want to go back on a point you just said there. When you said I'm an accountant, I started off in the post room in Mid Glamorgan Health Authority in Cathedral Road. I was there for 2 weeks, and on my last day, a lady working in the finance department fell over, stepping off a bus, broke her ankle, and I was asked to cover her while she was off on sick. And 39 years later, I'm still there. So
the rest is history. So I suppose, linking to that, probably the question that certainly I'm most interested in today is after 39 years in the NHS, what presents do you get when you get to 40 years?
I feel I'd missed out here, because I hear people get presents at all sorts of levels as they go in the NHS, but I've had nothing. But I'm waiting for that big one when I get to 40. I hope my boss Howell Jones is watching.
I hope the ship comes in. Yeah.
So what do you want then? What would be a good one?
Now's your chance.
Oh, what would be a good one? Oh, crumbs! A Cardiff City season ticket for life would be good for me.
There we go.
Well, Tim, so thank you very much for joining us today. We met last year around the time of the value funding streams. We had some conversations back then, and I'm, for those who don't know what you do, or maybe don't even know what the finance delivery unit is, can you tell us a bit about your day job? What does your inbox look like when you come in on a Monday morning?
Well, it's fascinating, because I've got to a level, I'm semi-retired, I'm 3 days a week now, and I've got to try and fit as much in as possible. And one thing I've learned about value-based healthcare, when I go to my colleagues in England, they mix up value-based healthcare with values and value, personal value. But I think there's a learning from that. Like, you know, for me, like values, not everybody working in the NHS in Wales have got the same values. I think somebody will come in, like I'm in on a Friday. I don't work Fridays, but I was so keen to come in to talk to you guys. I was here. The fact that you guys are here at 1 o'clock, 2 o'clock on a Friday afternoon suggests to me and people watching that they've got similar values to me, that we want to change and make a difference. So what I do in the finance delivery unit at the moment is a variety of things. We look at, we collect the monitoring returns from each of the organisations every month, and we give Welsh Government our assessment as to whether the monitoring returns as being presented are being true and fair, and whether we think organisations are going to break even when they say they are, or even if they say they're going to be overspent 20 million, they're going to do that. So I do that. I also got a role of looking out for efficiency opportunities. And to do that, I look everywhere across the border in England, Scotland, Northern Ireland, as well as benchmarking information that we've got readily available within Wales that I don't think we find. I then, with the team here, translate those opportunities into ways in which people like yourselves can understand where those opportunities are. We play back variation. We try not to make a call on it. So, for example, I'll give you a really interesting one. Adult mental health in Bevan. If you happen to be admitted as a patient there, you're likely only to stay in for 15 days in hospital. In Cardiff, on average, the adult mental health patient would stay 60 days. Now, to me, there's a variation. We need to understand that. Now, that variation's been in for several years. We know that caring for someone in the community is 30 times cheaper than caring for someone in hospital. And I know in Bevan they've invested in community provision. Now, what's missing from those two benchmarking bits of information is probably the most important one, which is outcomes. We don't collect outcome information very well. We started, but if we manage to get that, we'll be able to play back to those two systems. They can't both be right, can they? An average 15 days, average 60. My ultimate guess would be 15 days is what I'd want. I do have mental health issues, and if I go into hospital, I'd like to be made better very quickly, not wait 60 days. But those sort of variations are happening everywhere within NHS Wales, and we've got to look at ways to expose it, challenge it, and then move the resources into the right place. So that's the second part of our job. Promoting value-based healthcare is a major part of our job as well in the finance delivery unit, and it's probably the one that I believe means I offer the greatest value to the NHS. Looking at monitoring returns and looking at financial plans, I'm not going to really deliver the value I'm going to deliver to the system as much as when I'm sitting here now talking to however many, 30, 40 people, just tell you, my job, I see my job now is to create the value champions. Value-based healthcare, look, the NHS is in a mess. And the only way we're going to address the NHS problem is through value-based healthcare. But when I talk about that, I'm not just talking about investing in value-based projects. I'm talking about value being the day job. The £10 billion we get from Welsh Government, every time we spend it, we need to be seeing it with a value lens. I was really disappointed last week, and please don't quote me in front of the Minister, but I heard the Minister say, I found £30 million to solve the nursing dispute, but unfortunately, we may not be able to spend the same money on prevention as we would have liked this year. Now, that really was a bad, terrible thing for me to hear. My vision for value-based healthcare is a one where the Minister says, I need £30 million to solve the nursing dispute. And I've gone back to health boards to say, look at everything you're doing, look at what is not delivering good outcomes, and disinvest in those services to the value of £30 million so I can pay the nurses. We know £1 spent on smoking cessation will deliver £40 to the NHS over the next 20 years. So I really get annoyed when I hear we may not be spending all our smoke cessation money, because that's the wrong thing to do. And look, for 30 of my 39 years in NHS Wales, I was perceived and I felt like the enemy of the clinician. And I get it, because every time I used to meet my clinical colleagues, it was usually because we needed them to cut their costs, reduce spend. We've transformed our relationship over the last few years. We are now sitting down with you guys, talking about outcomes and how we can bring the costs and outcomes together so we can evaluate what is delivering the best return on our funding. It's, you know, some of the things we're doing at the moment, we've got to revisit and look at whether we would do it. I'm going to throw one in now, gluten-free products. We spend millions on gluten-free products that's given out on prescription. Now, I'm not sure, with all the problems we got, whether that's the best use of resources at the moment. And if we were starting the NHS off today from scratch and we were given £10 billion, would we have given gluten-free products on prescription as one of our items? And if we were, should we be giving peanut crisps to someone with a peanut allergy? You know, I understand why we started off giving the products out like we did, because they were difficult to get. Now they're readily available. That's what we should perhaps say, we perhaps need to look again at those sort of things. And there's loads of that going on across NHS Wales, but we're not very good at disinvestment at the moment.
So Tim, I think, it warms my heart to hear everything you're saying there. And I think both David and I are fully on board with this. And if we just come back to what you said before, you used the word efficiency, so what people hate, and we're jobbing clinicians. So the first of all is, how do we get more of you to sit with more clinicians, nurses, physios, docs, to sort of encourage this thinking, to think of our budgets and think of how we can shuffle things around, look at the low value components and the high value components, because we all feel safe in what we do every day. And as soon as we have someone comes in and shakes our cage and says, ooh, don't do it that way, don't do that operation, don't spend that drug on that, we get very defensive. And it's part of, it's not doctors, it's just human beings. We hate losing stuff and we hate changing what we do. So how have you had many of those consultations at the level I'm talking, and what sort of advice would you give?
Right, okay. Like, it takes two to tango. The finance professionals for years have been stuck in their ivory towers in offices. We are now no longer called management accountants in the main, we're called business partners. And we're called business partner accountants for a reason. We need to partner up with you guys to do exactly what you're saying. Now, I can give a commitment to everyone in this room. If you don't know who your business partner is, you work in NHS Wales, let me know, and I will find out who your business partner is. But I hope you will be welcomed with your business partner to go through all the services you do. Every health board has got a costing department, which we've got some incredible costing intelligence. We get down to patient level for most of our activities now. There is so much data out there that you probably don't know about, but you're right. The way forward is we have got to be sitting down with you regularly, looking at everything that gets done, capturing patient outcomes, working together on delivering the most efficient service. And yes, I understand people are protectionist, but I think the way to drive value now is by telling a story. Now, David met me last year and told me his story about his frustrations of getting pediatric, so a little bit of money to stop loads of patients coming to a paediatric A&E as inpatients into Cardiff. For me, it was a no-brainer, yet the system wasn't operating well enough that David's clear value plan got understood by everyone and it got implemented and spread and scale across Wales, is what I believe should happen. The finance professionals have got to come to the table, and we have got to identify the value champions, and you guys are the value champions, and there are thousands of value champions in Wales. They just don't know it at the moment. There's the lady by the name of Dr. Mel Thomas. She's the lymphedema lead across Wales. If you haven't had her in your podcast, I suggest you get her. She is absolutely brilliant. She's got a fantastic value story to tell. But I've learned so much working with Mel on everything to do with value-based healthcare. But Mel has been brilliant at both exploiting the system, understanding how to get the money, where to get the money, and then telling her story of what she's done with the money and how she's massively improved patient outcomes, saved loads of money. But what I love about Mel is last week she did a talk and said, Tim, we've tried virtual wards. We put a load of money in it. It didn't work, so I pulled the money and we stopped it. And that's what I want to hear.
That's brilliant. And what I'm liking here now is you're sort of, because again, as health professionals, we like to always have the right answer. And what you're talking about there is trying something, seeing that it doesn't work to the way you want it, adjust, react, put it again. Are you able to sort of give an example of something you've been involved in where you can just talk a little bit about the nitty gritty, the actual doing it, you know, so around a sort of a value-based project?
Okay, I'm going back to the lymphedema project because it's just, there's hundreds of things she's doing, Mel and her team, but there's a fantastic one where finance have been able to work very closely to deliver patient outcome and save significant money. So this is about cellulitis. Mel Thomas told me that if lymphedema is not captured early enough in the process, people often get cellulitis, potentially ending up in intensive care with cellulitis. And the problem with cellulitis, they make you better, and then a couple of months later, you're back in with the same problem. Yep. But Mel knew that GPs and clinicians within hospital settings aren't very good at identifying people with lymphedema. So we managed to get her the data on cellulitis. Every patient in 3 general hospitals to start with who had cellulitis. And Mel Thomas wrote out to every one of them and said, look, you might have lymphedema that we don't know, but will you come to an outpatient appointment where we could meet you? And then we could discuss with you how we can stop you having cellulitis again. It was a cold letter that said, and around the response rate of people saying, I'd like to meet you, Mr. Thomas, Dr. Thomas, was about 40%. But that was around, from memory, it was about 600 patients she met. Wow. She then very simply give them leaflets on how to manage lymphedema and tell them when to contact her when things were getting out of hand. And we've been able to track all those patients, and we know from statistics how often they would have had repeat cellulitis. And there was only 16 days worth of inpatient from that cohort of patients that accepted. They were only 16 days of inpatient capacity was used. Prior to that, they were using thousands and thousands of days. So this is what I did with working with Mel. It started off, we needed a little bit of investment, which was, at the time, it was a couple of qualified nurses to see all these patients. And we said we would be able to deliver savings. Now, the problem with the savings is those savings are not cash releasing. What I mean is you take a patient out of a bed, someone else will jump in it. However, Mel Thomas needed the money up front to pay for these extra nurses he was going to employ. So we have to tell the story. So the story, in the end, it went through DOFs, and it's sad that it goes through DOFs Directors of Finance.
Officers.
Yeah, DOFs, Directors of Finance, sorry.
Yeah, sorry, just...
And it was like, we just had to tell this story that we're in 3 general hospitals. We'd had this massive impact. A lot of general hospitals are bursting at the seams. So when we first started the initiative, it was about how we could save money and reduce costs. Now the story we're telling is a different one. We've proved the concept in 3 hospitals, the other general hospitals in Wales. We are now saying, if we don't do this, we're going to cause harm. Because we know all these cellulitis patients are coming back because they weren't diagnosed properly in the first place. And as a result, telling that story in that way has transformed how we've been able to get more investment into that area. And Mel has just spread that right across Wales. And I think she's in every health board now, working in most of the general hospitals.
So Tim, I've met Mel. In fact, when I think the first value meeting I went to a year or 2 ago, I stuck my hand up and asked some clinical questions, and somebody said to me, "Oh, you need to speak to Mel." Listening to what you've told us so far, there's a couple of things that jump out at me. The variation in mental health admissions between Cardiff and Anira and Bevan. So the measure is really interesting to me, because you're absolutely right. The admission, or the number of days somebody's admitted for, is not an outcome. That's a process measure. And it's really encouraging to hear somebody like you acknowledge that, and simply to say, oh, well, there's variation. Sure, it's a variation in a process measure rather than an outcome, but is a variation. So we need to understand that a little bit more. And I think, so I work in emergency care, and so people are aware of some of the common measures that get used to assess the quality of emergency care, and most of them in fact are process measures. They're not an outcome measure. So I was really interested to hear you talk about recognizing that variation is simply a reflection of something going on.
Yes.
We need to figure out what the variation in outcome is, not just that sort of admission.
I'll tell you a story, David, where I got myself in a lot of hot water, because I've learned through experience. I talk about variation. I'll leave you guys to say whether it's adverse variation, okay? I was working in the Anira and Bevan Health Board, and we found that the average length of stay of a trauma orthopaedic patient in the Royal Gwent was a day and a half longer than it was in Cardiff. And I went back to my clinicians and to say, look, they're getting them out far quicker than you. You know, you need to pull your finger out, sort of thing. Only to be presented a couple of days later with the data on readmissions. And the readmission rate at the time in Cardiff was significantly higher. And I learned a very harsh lesson. So I'm very careful on what I call, I just play back variation for you guys to decide whether it's good or bad.
And that's so-called unintended consequences, which clearly it isn't. It is, if you move someone out quicker, they're more likely to bounce back. So yeah, that should be the comprehensive data set, isn't it? And we tend to think of data sets rather than single points of data. So yeah, fascinating.
And I do feel sorry for you, because I imagine that every clinician you've ever spoken to believes they're truly special.
Absolutely.
I mean, so when you present variation and you say, well, Dave, actually in Cardiff in the pediatric emergency department, your admission rate is quite different to Newport or to the Grange or to Swansea, then I'll come back and I'll tell you, well, actually, we're a capital city. And did you know that actually these are all the reasons why we're different and special? So I feel your pain.
But we're good at this, so we're well experienced at this. I remember there was a type of knee prosthetics that was being given out in one of our hospitals that was far cheaper than the other knees being given out in a number of hospitals, and some work had been done to say that we could save a lot of money if we shifted to this cheaper knee prosthetics. And there was an awful lot of noise in the system about this, and basically someone said, well, the knee, look, you know, we are the specialists. I'm not saying it was Cardiff, but just say it was Cardiff. We know far more about this than they would in Hywel Dda. So we are using this knee, not that knee, because in fact, we think that knee isn't clinically sound and it shouldn't be used. So we went away. I went to the Royal National Orthopaedic Hospital in Birmingham and found out they were using the knee. Went back, played back to the clinician, said, look, the consultants in the Royal National Orthopaedic Hospital in Birmingham are really concerned now that you are telling them that the knees they use aren't clinically safe. Can you give us your evidence and can we see your data or whatever? To which they very quickly fell away and they've moved to our knees at the time. You know, so we have got strategies of dealing with that. We've got a lot of good relationships with a lot of colleagues across the UK who can help us in that defence.
That you've just told us about the dark side of the force. I think that's
and that's great. So just as a quick interjection here, we've got new attendees coming in, so it's just to explain this is the Value-Based Healthcast. We're very lucky in having Tim Kelland with us, who is the Assistant Director of Financial Delivery Unit, and we're talking really about the finances and the nuances, how we get things done, how we relate with financial information, rather than just sort of make it obscure. And we've covered quite a lot. So really, thanks, Tim. Just all of the different issues. Was there something you wanted to just bring up?
Yeah, it was going back, Tim, to something you mentioned earlier about costing intelligence, and that fascinates me because in a previous life, before I decided to become a medical student and go back and study, I spent a few years working in a financial organization. I wasn't selling bonds or stocks or anything like that. It was much more mundane. But
you were putting them into alphabetical order.
I was making the tea. But there was a manager in the department I worked in who had vast commercial experience. And one of his mantras was, make every decision like it's your business, like it's your own business.
Absolutely.
And I think that's a really, you know, when we talk about stewardship and public resources and our duty to the health system, one of the things I think is a real barrier to that is that everything's imaginary money, right? So we need a new bin in the department, and I've no idea how much that would cost. I've honestly no idea. And you know, if I take blood on a patient and I take out 3 syringes, if I use 2 and then put the other one in the bin, I don't know how much that would cost. And I think that would be so useful. I would love to be able to lead, you know, my team as if we were a business, because I think that focuses people's minds in a way that it's very difficult to do in the public sector. But I'm interested to hear your thoughts on that.
Absolutely. I think you've raised a really good point there. And I think I have seen in some theatre storerooms, the prices in some not health boards, some trusts in England, they actually put the price on everything, and it had a huge impact. People thinking, I never realized it cost that. But I want to go back to your point about the decision making and understanding it. And I'm going to give a really good story here. When I was supporting the pathology department in the Aneurin Bevan Health Board, they had a budget of about £18 million. And when I went to meet with the pathology directorate manager for the first time, he had an overspend approaching £1 million on 18 million. It was a bit of a problem. And I met with him and he said, there's nothing I can do about my budget because I'm a service organisation, and basically if they ask for a test, we do it. So I said to him, okay, look, you're a clinical director, you get paid a bit of money extra for being a clinical director, and part of that is managing the budget. But if you don't think you can control the budget shouldn't be with you. I could give the money to the people who request tests, and perhaps they will think twice about the number of tests. And I think that's something we all need to think about. Who's best to control the cost and give them the money first. But my the service manager at the time of pathology didn't want that. So I said, look, I wanted to think of it like this. If you get to £18 million and you've run out of cash, right? And the last thing to pay would be your own salary. Would you stop something within the £18 million you are spending to make sure you got paid? Am I making sense there? Yeah. So if he didn't have enough money, he wasn't going to get paid. I said, would you then look at all the tests you're doing and would you challenge the system back? And all fairness to this gentleman, he was absolutely fantastic business manager. We managed to get the budget back in line within a year. And the first thing we did together was I said, how many tests, different types of tests you were doing? And they were doing hundreds and hundreds. And I said, are some tests more important than others? And he had a big list and he said, oh yeah. And I said, are some tests you get asked a complete waste of money? And he goes, oh yeah. He goes, sometimes we get asked to do a test and we know at the start what the outcome is going to be because every time is a positive. So I'll give you an example. Vitamin D testing, okay? Every time in the Nile Bevan Health Board, they were asked to do a vitamin D test. It was positive. The person was vitamin D deficient. So I said, well, let's explore that a bit further. And the requests were coming in from GP practices. So we sat down with the cluster leads. And then we found out that the majority of these vitamin D testings were coming from a community where there were a lot of women who wear burqas. And the pathology manager said to the GP who was representing those, why on earth are you writing in for a vitamin D test? Because it's very obvious if they're wearing a burqa all day, they're going to be vitamin D deficient. And the cost of a test was £21 and a vitamin D tablets was less than £1. Just give them the vitamin D. And overnight, the amount of vitamin D testing was completely eradicated. It was taken away. And we were able to go through all the, I give you a simple one there because I remember it because it was such an interesting one. But that's the sort of thing we need to be doing. But it's exactly what you said it. We need to tell everybody what the cost is of everything somehow.
So something you mentioned there, I 100% agree. I just think it's so important. And how can we ever dig ourselves out of the hole we're in without knowing what things cost?
Except I would disagree because sometimes you can spend so much time worrying about the pence that actually, because what you've got your mind's clouded, not about the clinical decision making, but about the cost of something. And so for some people, that is more in what they want to do, and others want to look at the outcomes. And we just got to be careful we don't polarize. Now, your example of the vitamin D was a system change. It wasn't a cost exercise. You basically said, well, look, let's look at what are the outcomes we want. And what we want is effective bone health, for which vitamin D measurement or giving vitamin D will help with that. So let's skip the test and just say, well, to get the best health, we're just going to give the vitamin D. You know,
absolutely.
We don't expect every woman that they're pregnant, we're just going to give them the folic acid, you know, and you know, so there were these sort of things. I think you just pretty well.
Like as business partner accountants, right, we are going to do both. We have got to make sure that we look after, you know, that our procurement colleagues are buying tins of beans at the cheapest price. We've got to keep on top of them, you know. But what really annoys me is when I hear my DOF colleagues saying we got such a bad financial position, I'm putting a 2% cost improvement savings target on our drugs budget, right? That's such a negative thing to do, because
we call that just getting a bigger stick, right?
Yeah.
To beat the drum.
Absolutely. And it may be that if we do this properly, we may think the best thing to do to save money on the system is to put 10% more money into the primary care and secondary care drugs budget, because if we spend money on DOACs, we stop people coming into hospital, you know, and that's where we need to be together with you guys and our pharmacy colleagues, and we need to be, and it's all back, it's back to, look, the finance professionals are coming with you on this, and you've got to bring us with you as well. So, and your story needs to be told, and we need to do it together. It's a learning for all of us. It's all relatively new, but it is back to telling the story. We've got to get that story out. Where we can reduce our costs, then let's reduce the costs. But we got to understand how that impacts on the service. It's the cost of something, and the value is more important.
So it's the outcomes. And so we've just got some questions coming in, and please keep the questions coming. And it's just picking up on your theme. Now, before I go into that, I saw a patient this week where we use a high cost drug, and one other clinician wants to increase the frequency of that drug. So that could raise the cost from 60 grand a year to 120 grand a year. So what I did was I said, I was talking about it and how this drug works and how we might tweak things, or what other drug we might use. And I dropped the financial information into the conversation with the patient and said, look, as a custodian of this, I might, we might want to not do that and do this instead. And, just so they're aware, because otherwise it becomes one doctor's opinion to another doctor's opinion. And the question that comes in is, should we be giving financial information to patients? Should we be handing them a sheet of what it's cost? And would that influence their healthcare? And I wonder whether you had a feeling about that.
Oh, I'm going to tell you a story, and this is I put you in the position, okay? I used to work for an organisation called WISC, a Specialist Service Commissioner across for all of Wales. And within that department, I was responsible for the individual patient commission. These are the high cost requests for treatment, very high cost. We had a budget for the year of £8 million for all of Wales. And one request came in for a 9-year-old boy who's a haemophiliac. And basically, they needed a blood product for that boy that if he remained on that blood product, it was going to cost over £1 million a year.
Yeah.
I sat in a room, and the panel consisted of a medical director, the nurse director, and myself. And we had to make that call. And the ruling at the time was, if we all agree, it's a consensus and the decision's carried. If one of us doesn't, it gets escalated to the next level. So my medical director said, well, I can tell you now, if we give the blood product to the boy, it will work and he will live a normal life with that. If he doesn't have it, he will die. It was £1 million. We only had 8 million for all of Wales. And my questioning, I didn't like this job, by the way, was what happens if we have 8 children come along? What are we going to do? Where do we draw the line? And in the end, we could not agree. So it got escalated first to my chief director of finance, then the chief executive, who then went straight to the minister, who sent it back saying, I pay you to make those decisions. Okay. So anyway, that decision was then taken by the board to a public meeting. Now, the public meeting wasn't to discuss the child individually, but the what if scenario, if a blood product came in at £1 million, and the board met, and the family took the child to the board meeting. So basically, you look the child in the eye because the child is going to die. And guess what decision the board made? We'd fund it, of course. And I'm really pleased that they did, because it was only 3 months in, and then they had then developed another blood product. It was a lot cheaper than the child is. It was years ago now, there's 6 or 7 years ago. But it's another question. It's like, do we bring, into David's question, do we bring that to patients? I'm not sure it would be helpful. The clinicians need to know it. I don't think it was helpful that a clinician came back and said, this is £1 million. Because I asked the question, what if it was 4 million? Where were we going to draw the line? And perhaps we need a discussion on where we do draw the line without any patient being attached to it.
Do that already, and that's why we have NICE. And, you know, that's world leading. And so it does judge on this about whether...
I'm not sure, but there are exceptional circumstances. I know of patients that cost hundreds of thousands, millions of pounds, whereas the cost per quali, I think, that NICE started with, I don't know what it is now, was around £30,000.
That's right.
So we know of lots of patients costing over that.
So Tim, sorry, go on.
Yeah, no. So we could talk about this all the time, but we also know there are contingency funds for this sort of thing. So it's not just straight out of one budget, you know.
But it's coming out of the 10 million, 10 billion, sorry.
Would have a wet weather budget, you know. So you have your normal budget, and then you have the things for the things you didn't plan for. And so I don't know whether that's part of the consideration. Sorry, David.
Yeah, so Tim, look, again, bringing a child to the board meeting. Wow, I mean that is that's tough stuff. Yeah, but it does bring me back to patience, doesn't it? And so listening to you talk about the pathology service manager with a budget of £80 million, and your question to him, if your salary was the last thing to come out, you know, what would you do differently? And that, for me, it comes back to the same question as my old boss used to ask me, which is, or his mantra, run it like it's your own business.
Yeah. So
that's sort of a skin in the game, isn't it? Like, yes. A guy called Taylor wrote a book about that, a skin in the game. What he's saying basically is, like, it matters to nobody more than the person who's right in the middle of it. And for me, where do the patients come into this? So one of the interesting things for me about being a doctor, one of the challenging things is that I feel like communities and individuals and populations have become quite detached from health and healthcare. And with the value, how do we bring patients in on this and really and help them choose or help them drive it?
Like, my vision is this, okay? Often the patients do know best and the staff know best as well. We've got to get mechanisms by which, where patients got ideas for adding value, how they can improve value, we've got to incentivize them to tell us and bring to our attention where they feel there is no added value. Can I share with you a letter that I'm going to share with you on screen? Now, for me, this is a letter that my mother received as an 82-year-old. And this is, for me, this is about everybody in the process being disengaged and not adding value in any way. But if I show you, can you see my screen?
You might need to make it presentation mode.
Oh, right, okay.
But we can see it, yeah.
Slideshow, current slide.
Read it out to us. Okay, here we go.
All this is, my mother is an 82-year-old lady. She had a problem with her memory. And she went to see the memory clinic in Royal Glamorgan. And I've had permission off my mother to share this letter, by the way. They solved her problem. She had cardiac problem, actually, it caused her memory problem. But she then received a letter on June the 3rd, 2019, to come back for a follow-up appointment the following year in June. Now, the irony of a mental health patient at 82-year-old being asked to come back in a year's time wasn't lost on me. So I then rang this place because I was so angry that, first of all, the doctor said he wanted to see her in a year's time. But secondly, that somebody typed a letter, somebody, you know, this is active disengagement. I think somebody sort of said, this is stupid. So I rang up and I asked, what's the DNA rate for this clinic? To which they said, because of the type of patients they are, they would expect it to be low, so they don't collect that information. Now, I think this is active disengagement for me, you know. Now, the problem is my father is a very traditional, he's a former headmaster, and accountants know nothing, doctors know best. So my mother every year gets asked back to this clinic, and my father goes, how'd she get on, Dad? What's the matter with her memory at the moment? Oh, nothing wrong with her memory. Well, why are you going, Dad? No, the doctor wants to see her. He's been good to us, you know. So she goes to see him and she gets asked again. Now, my mother had 6 letters following that first one, changing the date, changing the time, changing the venue. I know everywhere I go, I'm seeing things like this going on. And it's easy for me to throw stones. I'm not picking on that service particularly, but patients often say to me, we're being asked to do that. And we should have a system by which we can bring ideas back to us so we can start challenging the system. I'd like to be the executive of system removal, because I think that's what we need to do, instead, because what we're really poor at, by the way, and I wanted to bring this up earlier, what we're really poor at in Wales is benefits realisation. Now, I don't know if any of you guys have been to a board meeting with our poor execs and non-execs. A typical board meeting will have papers and it'll be bigger than that. And they're expected to read those papers over a period of like 7 days. It's never going to happen. They all go and they might read some of them. But often a good written business case will get the money and a bad written business case won't get the money. But just because someone's good at writing a business case, the money's going to go into the wrong place. But how often does that same board do a benefits realisation as to, we put the money in, did it deliver what it said it was going to do when we signed it off? And if it didn't, should we revert back to the norm and pull the money out? And that's just I needed to get that one off my chest.
So, and some of this is about how do we get stuff done? And, you brought up the case of the lymphedema, and it's never just that easy. As you have an idea, you roll it out, you test it, 600 patients, show this, scale it up. It doesn't work that way, does it? Because if it did, then we'd all be doing it and we would be flush. So what sort of key things, apart from a good business case, maybe, 2 sides of A4 would work really well?
Absolutely. I was just going to say, right, I think 2 sides of A4 with the very first part saying, what are you going to deliver in terms of outcomes?
Yes.
And, and if the outcome is I'm going to prevent patients going into hospital X number of patient days, let's put that on. And if we can put a value to that, let's put a number to it, a financial value to it, because, that'll stand out. So if the investment's 100,000 and it's going to deliver £2 million worth of savings, that needs to be right on the front page, and it'll be very difficult for people to ignore. But we do have to
hold them to account as well.
Absolutely. But also, I think when we do a 2-pager, we should not just be focusing on the saving to the NHS. I think we've got a duty to report the saving to the Welsh public purse. Yes. So if I give you an example, they invested recently in Cwmtaf in a load of physiotherapy support in GP practices, which meant patients were going to be seen by, as soon as they go to the GP, they needed to see a physio. Instead of the previous 6 months wait to see the hospital physio, they were now being seen within a few days within the GP practice. Now, when I saw the business case for that money to be extended, because that was a pilot, I was a bit disappointed that nobody had said that these patients could have been 6 months off work, waiting to see a physio. And that, you're a burden on society as opposed to contributing to society. And we've got a vested interest to make sure all our population are contributing, especially in the current climate, where we got an inflationary problem, and we need to support the foundation economy of Wales.
But we don't have a system at the moment that allows for that, So when we had the Department, of Pensions and disability came out of that budget, for the management of disability, and then they changed that, I think, back in the 80s, and then no one holds that budget. So rehabilitation is not really something, getting people back into work and getting people off pension benefits. We just don't measure that now.
Yeah, but look, for me, I think, yes, we've got to talk about the impact on the NHS. But what is really important as well is that we got a duty to the taxpayer. Whether it's UK government and we don't know where it's coming from into the system, we still got to get the best return for our taxpaying population.
Sure. So we got a question here from Hugh Williams. And he's talking about relationships. So what do you feel are the main challenges in terms of professional relationships of clinicians and those from the FDU?
Well, look, don't link the FDU on this. Let's talk about the finance profession, because there are financial business partners throughout the NHS. And the question has got to be, we have got to get in a room with all of you. You may not be the budget holders, but you are spending NHS resource. We need to get a lot closer to you, and you need to get a lot closer to us so we can help you deliver the best outcomes for your population.
Who else then needs to be in the room so we get stuff done?
Well, you need the budget holder, the service manager, because the person who's got the budget for this needs to be involved. And one of the problems we got, and it's a big challenge for NHS Wales Finance, right, is our budgetary control processes and our performance management framework is not supporting value-based healthcare in the way I'd like. So, for example, if I spend 5% more money in drugs, I may save people coming into hospital, but that might be two budget holders. And the pharmacy person may be saying, hang on a minute, I'm going to be wheeled in and have a row for overspending. So I'm not prepared to spend the increased 5% to save money in someone else's area. Right. And the finance professional has to make sure we navigate through that. And that is going to take engagement across the professions and between finance business partners, and often between organisations. So, for example, investment in people in Powys, in the locality of Powys, might save a load of money in some of the hospitals in Cardiff, because that's the flow. So somehow we've, value-based healthcare, as I said, is the only way. We're going to have to somehow square this circle, but that's, we're still in the process of trying to work out how to do this. But we're ready as a finance profession. We're ready to do this with you.
Right, Tim. The thing jumping out of me is so I work in the emergency department in Cardiff, and so we're part of the medicine clinical board in Cardiff. I know we have finance and accounting people in our clinical board. I think Rebecca Warren is one of the people who coordinate.
Great, Rebecca.
Well, I'm asking myself now why I've never invited Rebecca down to the department to walk her through and do a patient journey. It's something we do from time to time. And I don't know why it hadn't occurred to me to do that. And now I'm thinking, just when I get back first thing on Monday, I need to find a time to do that. Because
invite your director of finance as well. Why not?
Yeah.
But look, is a lovely start of Mel Thomas's presentation that she did to our finance profession. Is a picture of I think it was the Queen. It was Tony Blair. There was the President of the United States. There was a list of Nelson Mandela. There was about 8 people on that list to show pictures of, and she said, who's the odd one out? And the answer was Boris Johnson, because that's the only person she hadn't met. And what Mel realised very early on, you've got to get to know these people.
Yeah.
And it was interesting. I went to a Medi Wales Award where Mel Thomas picked up a nice award there. But it was very interesting that she had a queue of people waiting to speak to her. And at the front was Judith Paget. Mel had created this but she just plays the system. You know, invite the people in, the influencers. You know, you've got to, if you want to get money, there's no better person to invite in is the director of. They might not come and might send you a deputy, but you've got to get them to understand where you are coming from. If you want to get the investment in, same with your chief executive, be bringing them in as well.
Yeah. No, I just food for thought, and all the time looking for different angles, because like you say, it's telling the story, creating the narrative. I think a lot of value in value-based healthcare is about that. Muir Gray talks about the language of change, and you know, the narrative arc, and these things clinicians and accountants, I'm guessing, are at our best logic-based creatures. We like to think we're based our decisions in scientific rigor or logic. Now, I know that's not always the case, but we have to sort of step outside that lens or that frame sometimes to think, well, actually, there's another bit here, which is how we tell a story or how we bring patients in. So, Nick, can I
put a quick plug, because I think it's really important that we can do this, right? The Finance Academy in NHS Wales do a Value into Practice program. I don't know if any of you have heard of it, but it was the brainchild of the NHS DOFs in Wales, the medical directors and the directors of operations. And what they do is a 6 months training. It's like, you know, probably six over a period of 6 months, where they train people up, taking you through all the toolkits and data available, how to design patient outcome to help anyone who's interested in drive through a value project. And there's an application process, but it'll be, every project will have a clinical lead, an operational lead, usually a director manager, and a business partner accountant. They have historically proved to be quite successful, but I was really disappointed last autumn when we didn't have enough applicant supply. I think that was down to our marketing, but I would really be interested. I would like to share with you guys after this details of when the next program is. It's a fantastic program. Anyone who's been on it has spoken highly about it.
Well, Tim, so if you have that detail now, you could pop it in the chat bar, but definitely if you don't, and even if you do, if you could let us know, and what we'll do, because we email everybody who listens to the Value-Based Healthcast with a sort of wrap up afterwards, and we can make sure that's in there and on the website as well for the Value and Health Centre.
Excellent. I haven't got it now, so I'm not sure when the next program is going to be launched, but I'm going to make sure that every one of you guys get to see it.
And if you've got any other tips, because one of the things we'd hoped to get from you, I think this has been a brilliant discussion, I've really enjoyed it, is if you can signpost us or our audience to any other potential tools or resources would be really good too.
Look, what I'd like to do, if you guys would be up for it, is like, we have got a program we could run for a day. It'll probably need to be an in-person one, where we can bring some clinicians in who have followed the process, like people like Mel Thomas, who's always pleased to talk. Then we could have a session whereby we will explain to you all the tools and the data available to help you drive a project. And then later on in the afternoon, then we can perhaps talk about how we as a finance profession, and we can make sure there's business partners in the room where we can help you drive a project and support you, or you know, anyone who's interested.
And I think that'd be brilliant if you've got if you've got finance professionals who, as well as health professionals, working together so they could understand each other's language. Because for me, sometimes, you know, one of the reasons I've come to Wales is to meet people like you, but that wasn't necessarily the culture of where I've come from. And so why was that the way that was, and why is it the way that it is now? And what I've realized is there's more communication, more talking here, which I think is one of the key points that we brought out of this. So, but it's getting, you know, the two groups or the other, you know, as many groups together, so we all understand each other's story, and what value we bring. Sorry, David.
No, spot on. Yeah, and I was just thinking that, Tim, if we manage to pull that together, then it'd be really interesting to maybe get some of the participants back to talk to us on the Value-Based Healthcast, because we're all about how to get stuff done. So you know, no better way to do that than speak to the people who are on the journey. Yeah. But that's just about bringing us up to the end of the hour. So, you know, Nick, what have you picked up from talking to Tim? What are the sort of the nuggets from today?
I'd have fire in the belly. Believe that you can make change, and think systems as much as possible rather than just efficiency. And I think you've illustrated some fantastic examples around that. So thanks, Tim.
Brilliant, thank you.
And for me, it's about, you know, I keep coming back to, you know, skin in the game. If you're going to drive value, then, you know, think about it, you know, bring your patients in, make it real for them, listen to them, you know, run it like it's your own business. All that you're looking at all these value points and making it real. If we're to stand a chance of driving care on for the next generation in NHS Wales.
And just remember, right, the finance professionals are your friends, okay? I remember speaking to a colleague, former consultant colleague, who frightened me to death when I first met him. And then I said, look, I'm going to assume you know nothing about finance. And he went, oh, thank goodness for that. He said, because I've been made a clinical director, I've been given a budget, but nobody's ever taken me through how to manage a budget and what I got to do and financial governance. And, you know, we are here to support. I know the majority who wouldn't have had that as part of your medical training. You probably had no financial understanding. We are here to help you in that regard, and please use us all.
Well, Tim, yeah, from us, from Nick and I, from Sally Lewis and the Value and Health Centre, thanks so much for hanging out with us for the last hour. It's been brilliant.
Brilliant. Thanks very much, guys. I really enjoyed it. Take care. All the best. Thank you. Bye.